All right. Well, thank you everybody for joining us this evening. Hello and welcome to the MAPS National Committee's Addressing Maternal and Child Health Disparities webinar series. This series was created to help inform pre-medical students and MAPS associate members about the importance of maternal health and how health policies have affected minority populations, especially the African American community. My name is Stephanie Taylor, and I am the National MAPS Health Policy and Legislative Affairs Committee representative, and I will be your host today. This evening, the National MAPS Committee is fortunate to have Dr. Alisha Leggett. Dr. Leggett is the founder and executive director of Empower Her Health, a board certified family medicine doctor and teaching facility or faculty at Phillips Family Medicine Residency Program in Sleepy Hollow. Since completing her training in the Bronx, New York, she has honed her passion for reproductive health and health equity while working as a family doctor in New York's most medically underserved neighborhoods. In her current role, she is a resident physician educator. She helps residents
Okay, I found this on the
take,
web for this series was created to help inform pre.
excuse me, she helps residents take a critical lens towards systemic injustice and train them to be change
Here's what I found.
agents. She believes that it is important to provide patient-centered, culturally responsive care in order to improve the excellence for Black, Indigenous health consumers. Please help me welcome Dr. Alisha Leggett to the stage.
Hello, everybody. I hope everybody's doing okay this evening. As Stephanie mentioned, I am Dr. Alisha Liggett. I'm a family medicine doctor and also a teaching faculty at Phelps Family Medicine Residency Program. I'm happy to share this talk that I created for our residency program with you all today, and it's called Reproductive Justice. This topic I feel is critically important when speaking about health equity, especially as physicians of the future are really kind of trained and indoctrinated in how to provide culturally responsive reproductive health care to all individuals who are birthers, non-birthers, really across the lifespan as well. So I hope this topic will be enlightening. One of the reasons why it's important to really speak about reproductive justice is because it really does specifically highlight the patient experience, our experiences, particularly as communities of color, as we interact with healthcare, and really center what the barriers to good care are, right? Really um, center what are some of the root causes of some of the health disparities in maternal health and reproductive health that we see. And part of that, at the center of that experience, is really racism, right? Discrimination, poor treatment. So, in really talking about reproductive justice, we're really talking about how it is we can kind of move forward to ensure that some of those gaps are bridged. All right. So, reproductive justice is a theory and a practice that aims to empower people to make their own choices for their families and for themselves. It's about centering the experiences of marginalized communities, as I mentioned, and providing high quality care. And it's also about understanding discrimination and inequity and how these experiences often define people's people's perceptions as they interact with healthcare practitioners and systems, influence choices and outcomes for overall health. So today, let me see, go to the next slide. Okay, there we go. So this is obviously going to be something that this talk kind of touches on some issues that are often very sensitive for people. It's not going to be as interactive as I would have hoped, but that's okay. You guys can certainly put any comments you have in the chat if you have questions or concerns. But sometimes some of the material does hit people in ways that they didn't expect. So I always just encourage people to kind of create a learning environment that's inclusive and respectful of others, irrespective of their current knowledge, questions that they might ask, because this is really an opportunity for everyone to learn and grow. Some of us may already believe we practice inclusivity and equity and can navigate situations well, and some of us not so much. So it's just important that we can be present. That means we take space and make space for others. That we create a brave space, which means that what's said really stays here. What is learned here leaves here, so you actually can apply what you learned. That you kind of really listen and or read, in this case with the intent to understand. You can ask for what you need. You can ask for clarification, and also just to reserve judgments. Okay, can you guys see my slides okay still? Okay, all right. Did you want to move? Okay. Okay, so the learning objectives for today is going to be, of course, to define reproductive justice, because this can be a new term for many individuals, and kind of really understanding what that is. And I really use the definition that's put forth by the Women of Color Reproductive Justice Collective and or Sister Song, which was one of the first organizations to really coin the term reproductive justice. We're also going to address the historical and contemporary context of reproductive injustice. And this really includes that history of reproductive exploitation in this country and how this history really created pivotal systemic discrimination and how that really drives disparities. And then we're also going to review how we can really adopt some of these reproductive justice principles and integrate them into our clinical practice. Okay, so I would like to show you guys a video because um, we have two reproductive justice advocates, staunch advocates, who have been doing this work for many, many years and created a YouTube video that I'd like to share. This is Dr. Monica R. McLemore and Dr. Karen Scott speaking about reproductive justice. Here we go.
If you justice, you develop a construct called reproductive justice.
Reproductive justice started as a analytical, as a framework, as a movement, right?
But in 1994, several Black women really actually coined the term.
And it really started off thinking about sex associated with reproduction, right? Produces a pregnancy. And so what are the rights of that person?
It is a human rights-based theory and praxis that posits four very important things. People have the right to create family and to create kin in the ways that they see fit.
What are the options available to you if you choose to pregnant and to birth, right? Birthing shouldn't really be totally in the hands of OBGYNs. And I say that as an OBGYN, right? So how do you think about the birth workforce and the birth support team?
They have a right to prevent and or in pregnancy if that's something that they need to do for themselves and their families.
What to do if you want to end the pregnancy, and how do you do that with dignity and safety and respect?
They have a right to parent with dignity without manipulation, coercion, or violence from any individual or from the state.
People who currently have children, what are the supports and services and accommodations that the community and the government are accountable to our community to ensure that people can continue to parent their children the way they want to in the family composition that they choose?
They have a right to disassociate sex from reproduction, which I think is really important because then that affords us opportunities to have discussions around consent, healthy sexuality, pleasure.
And RJ opens all of that up so that we really think about options and power and autonomy and not control, constraint, or coercion.
Okay, so, some of the words that are shared during this video, options, autonomy, respect, dignity, humanity, fairness. These are things that kind of jump out to me about and how we would describe reproductive justice, right? And I encourage you all to kind of write down what you heard and kind of what resonated with you as well. And please put any comments in the chat that you may have. Okay, so far no comments, so we'll keep going.
If you think about the combining of
Sorry. Okay. So in reviewing those four tenets of reproductive justice that they posited during the video, that is the right to create family, right? So the right to create family, however we choose to do that. That could be through birthing a child, that could be through adoption, through IVF, IUI surrogacy, any sort of medical procedures, embryo donation, a right to create family, and really the right for our family to look and feel however it is that we feel is right for us, right? The right to live child free and to prevent and or end a pregnancy, right? So that means the use of contraception, having access to that, the use of emergency contraception, safe abortion, and also having access to abortion, as well as adoption, right? The right to parent in safe and fruitful environments, meaning that we can raise our children in places that are clean, places that are safe, places that are healthy, places that are free of coercion from the state, from police harassment, places that are resourced with equity in comparison to other communities nearby, um, and really, uh, an opportunity to really raise children in an anti-racist society, right? Free of discrimination, free of the fear of interacting with health and social systems for fear of discrimination or backlash, right? And the right to disassociate sex from reproduction. Again, kind of speaking about issues of consent, healthy sexuality, sexual pleasure, and autonomy. So all of these things are I think, really kind of are brought together quite nicely under this umbrella of reproductive justice, and really allows us to think about what it means to kind of have power over your choice, and to have autonomy over your body. Okay, so as I mentioned previously, reproductive justice is very much about centering experiences, right? So it's important for us to understand what those experiences have traditionally looked like. The United States has had a very long history of reproductive injustice that has been perpetuated largely against bodies of color. We have participated in over 300 years of reproductive slavery, which included forced sexual relation between enslaved men, women, or girls, forced pregnancies, favoring young girls to produce large amounts of children, and also really using this reproductive exploitation as a means to really spur the economic engine of the United States and really drove prosperity in the United States. This process of forced breeding really became more popular after the prohibition of the slave trade, when really reproduction became critically important to continuation of the practice of enslavement. We also have another example of reproductive exploitation, and really this is in the form of research, where Dr. Marion Sims, who was really arguably the father of gynecology, modern gynecology in the United States, was a famous American gynecologist in the 19th century and also president of the American Medical Association in 1880. He invented the speculum, and he also perfected a specific surgery to correct the vesicovaginal fistulas, which is kind of this imperfection or tear between the uterus and the bladder, which was at that time was very common after childbirth for women to have this issue, and it resulted in tremendous pain and often kind of leakage of fluids between the uterus and the bladder. He perfected this procedure on enslaved women. So before kind of popularizing the procedure among the masses, he really kind of used enslaved women as a means of perfecting the procedure, and often performed surgery on them without anesthesia. The picture that we see here on the right is actually a recent photo that was taken in 2018 of women who are standing in protest in front of the statue that once stood in Central Park in New York City, but was taken down in 2018 due to protests. And really, you can see they're wearing hospital gowns with fake blood on them to really demonstrate that reproductive violence that took place against these enslaved women, whose names we should say and we should know: Lucy, Anarcha, and Betsy. Another example of kind of exploitation in the realm of research or investigation was really the case of Miss Henrietta Lacks, who was an impoverished tobacco farmer from Virginia and who died of cervical cancer. At the time when she was alive, Johns Hopkins was the only hospital in the area that really treated Black patients. And The physicians who treated her noticed that her cancer was advancing quite rapidly and was quite out of the norm than what they had seen previously. So, what they did is they thought they would perform some investigations and research on her cells and really took samples and biopsies from her cancer cells without her or her family's consent to use them for research. Now, these cells are still used today in 2024. These cells were used to create the first, what we call immortal cell line, which is called the HeLa cell line, leading to a cascade of medical breakthroughs. And this includes the discovery of the polio vaccine, chemotherapy treatments for cancer patients, gene mapping, in vitro fertilization, and even the COVID-19 vaccine. So these kind of examples that I just gave you really kind of fostered this mistrust for patients of color, particularly to participate in clinical trials, where we know diversity has been very necessary to create generalizable outcomes. So far, we really heard about examples of reproductive exploitation, slavery, unethical experimentation, but I also want to provide you with an example of sterilization abuse, which is also a common practice in the United States. So the US government participated in a state-sponsored sterilization campaign, and the one that we know most famously was the one that was sponsored to really target Indigenous women through the Indian Health Service. And it was really something that was funded by the federal government. So this program started in the 1960s, and it was initially funded as a family planning initiative aimed at Indigenous women, and really became legitimized by the government through appropriation from Congress. But the issue with this funding is that it gave extreme latitude to doctors to really interpret and coerce women into sterilizations. And I'm sure you all are aware of how powerful implicit bias and explicit bias can be, especially because physicians hold so much power over how patients make decisions about their health. When you think about who the doctors were at the time, these doctors were most commonly white, middle class, Protestant. They held their own views about what family structure should look like in their communities, and really kind of imposed that upon Indigenous communities. And this resulted in about 70,000 Indigenous women becoming sterilized, coerced into sterilization, which was about 25 to 50% of the women of childbearing age at that time. So the photo of this woman, who is an activist and an advocate, Miss Maria Sanchez, she spoke before the UN in 1972, really trying to highlight this issue as a major problem for Indigenous women, and also highlighting what that experience was like for women and their increased discomfort and mistrust in receiving services from the Indian Health Service. Another example that I can give you of contraceptive coercion, like sterilization abuse, is this issue, the issue of the Norplant, which was kind of predates the Nexplanon that we have now. I don't know if you all are aware of that, but it's a form of contraception that's a very popular form of contraception at this point in time. But the Norplant kind of preceded that. And within days of FDA approval of this Norplant, the first long-acting reversible contraceptive, it became clear that this form of contraception could be and would be weaponized against women of color. Legislators in 12 states pushed for mandatory contraception with the stipulation that individuals who were receiving public benefits would lose them if they did not comply and accept the Norplant. None of these bills passed, but this newspaper article that I have here that was published in the Philadelphia Inquirer really kind of encapsulates the sentiment at the time. They asked, poverty and Norplant, can contraception reduce the underclass? The underclass really coming to represent individuals who are poor, who are marginalized, and who are of color. So many state legislators around the color pushed this legislation to make Norplant mandatory for low-income women receiving public benefits, but none of this passed. I should also mention that Norplant was tested and heavily promoted in poor Black communities among teenage populations, really drawing on that legacy of experimentation in communities of color. And all of this occurred despite the severe side effects that many of these women experienced, including heavy irregular periods, headaches, and weight gain. And literally the list goes on and on and on. And we're all the way up to 2020 at this point. And on, right? So this history of reproductive injustice continues. And it continues, right? And it really kind of speaks to the issue of, if this legacy of injustice is able to be perpetuated through centuries, what is really driving this, right? And as we know, it's something that we call systemic injustice or systemic racism that is really at the heart of driving reproductive injustice in this country. So when we look at how we can situate the current inequities that we see in reproductive outcomes for women of color with the context of this history that I just kind of outlined, we can see that there are a lot of legacies of intersecting oppression and inequality that kind of come to light. One of the most notable examples that I'm sure many of you are aware of is the issue of the maternal mortality crisis in the United States. So the United States is the least safe place in the developed world to birth, and that's primarily due to maternal health outcomes among women of color. As you can see from the chart that I have up here, Black women are 4 times more likely to die of pregnancy-related causes. They make up 15% of the live births in this country, but 36% of the pregnancy-related mortality. Studies have really identified racism as a key driver. And we can see also that as the years go on, this is something that is just becoming worse, right? So it's important for us to really think about, like, what is driving this? And as you can see as well, the numbers are really climbing for every group. Also, when we look specifically at disparities in cervical cancer diagnosis by race and ethnicity, we can also see that there are disparities that we see here. So we see that Black, American Indian, or Alaskan Native, Latinx women have higher rates of cervical cancer and also lower survival rates, right? And we can, when we just think about, like, what are some of the barriers that even prevent people from accessing this type of care, to get a pap smear to prevent cervical cancer, I mean, the answers are very clear. Much of it has to do with lack of health insurance or lack of access. Cost is a frequently reported barrier if people don't have insurance, and also poor follow-up for abnormal results. So how easy is it for people to even access care? We can also just look at rates of uninsurance by immigration status. And immigration status is a big one because we often see that undocumented status in particular really correlates to poor health outcomes because of lack of access to care. And that's really due to the significant restrictions that insurance place on really preventing people from accessing it. And that includes sexual and reproductive health care. When we even look at the current case of all of the rollbacks of reproductive rights, abortion rights across the country, we've seen that so far that 24 states have banned abortion or are likely to do so. And this really represents an erosion of access to a much needed reproductive health service that for many women is really, really critical to their health and well-being. So this, by really rolling back these provisions, this access to a critical right, and also a critical necessity, a need, healthcare that's so critically important, it's really kind of robbing individuals of the ability to really reproduce or not reproduce freely, right? This is a great example of reproductive injustice and how it directly speaks to how those tenets of reproductive justice are really violated, that people don't have the autonomy to make those decisions for themselves and for their families, and also robs them of the ability to really access abortion safely, right? So these things are all important to think about. One of the things that I had mentioned previously was just about the experience as people enter healthcare and what kind of that intersection between this legacy of injustice and what that looks like today. So talked about some of the health disparities that we see, but it's also important to speak about how people are treated. We know that this comes in the form of microaggressions, macroaggressions, implicit bias, and how really the attitudes, the actions, and behaviors of healthcare individuals who render healthcare, and that's really from start to finish. So that includes people at the front desk, all the people who are nurses, physicians, nurse practitioners, PAs, literally everyone who interact with patients, and what the experiences of those interactions really look like. So I like to kind of split them into two facets, one being areas of omission, where, people are just not doing what they should be doing, right? And things get overlooked, things get missed, and misdiagnoses happen or bad care happens, right? Or areas of commission, where people are just, assuming malintent, making discriminatory comments, having abrasive bedside manner, breaching confidentiality, basically not giving patients the same options based on their background, experience, and assumptions that we make about them. So this is a critically important driver to poor outcomes as well. And when we think about that implicit bias, I'm just going to skip ahead a little bit. When we think about that implicit bias and what are some of the specific aspects of a person's experience, a person's background that really kind of start to cloud our judgment, these are some of the things that come to mind. Someone's religion. So we've seen an uptick in Islamophobia, for example, occupation, housing status, their race and ethnicity, where they live, their citizenship status, their educational status. So based on these things, we kind of start to make assumptions about people that may cloud our ability to really to help them make decisions that are best for them and their families. I'm just going to skip back again and talk about how it is we practice medicine today and how this legacy of discrimination really is perpetuated even in how we interpret our clinical algorithms. So healthcare in this day and age is really moving towards more of an evidence-based model where we're really trying to use data to help us to make objective decisions about patient care. Although we know that data isn't everything, it can certainly help us to standardize certain treatments as we need to for patients. But what we're finding is that some of these clinical tools that we use, for example, the heart failure risk score or the eGFR, which is the glomerular filtration rate that we use to quantify someone's renal or kidney function, and even the VBAC risk calculator, which is also another calculator we use to ascertain someone's risk for having a successful vaginal birth after cesarean. All of these algorithms, there's race built into that. There's a race correlation. And what happens is these race correlations essentially bias us to make decisions that might be different if they weren't in effect. So for example, the VBAC risk calculator, since we're talking about reproductive health, which is the vaginal birth after cesarean risk calculator, the correlation or the correction for race really subtracts from the estimated success rate for Black and Hispanic women. So that means that Black and Hispanic women have a greater chance of having a lower score based on this risk calculator, and thus the calculator will predict a lower chance of success with VBAC. So that means that Black and Hispanic women, when we use that calculator to then counsel patients, we are more likely to encourage them to have a C-section versus to a trial of vaginal birth after cesarean. And we really see this reflected in some of the data around cesarean sections, where women of color have higher rates of section. So as I kind of wanted to kind of bring this all together and thinking about how racism really plays a role and what is kind of the practice that contributes to the perpetuation of systemic racism in the way that we practice and render care, we can really kind of see this in 7 parts, right? Or 6 parts, which is safety and So safety and accountability is a big one. So how patients feel both physically and psychologically safe when they interact with healthcare staff, when they interact with doctors, and how it is that we can respect their decisions, how it is that we can really communicate in a way that makes patients feel safe. Autonomy is another one, where we can really empower patients to voice their concerns, their preferences about their care, and we can really respect that. The social network and kinship. So, really encouraging patients to lean on their social networks, encourage them to bring support persons. Data often shows that people who show up to doctors' offices alone will get worse quality care than people who show up with an advocate. So, it's really important to encourage patients to bring individuals that they trust and that can support them. Communication and information exchange. So how is it that we communicate with people? What is the tenor and tone that we use to communicate? Are we having conversations with people, or are we really just dictating to them in a very patriarchal fashion what it is that what they need to do, as opposed to really employing methods like motivational interviewing or shared decision making communication techniques that really allow for more equity in communication. I talked a little bit about racism, but racism really at the root of that is about a power dynamic that plays out on the basis of race. And that really kind of brings into play the implicit and the explicit bias that I mentioned before. The lack of empathy that we have, the lack of humanity that we show for patients, and really how burnout can contribute to that too. Just being tired, really feeling as though we're unable to make that human connection with people because of the way that our systems are run. And of course, dignity and Blackness in holistic care. So this means like promoting doulas, for example, when we think about birthing. How it is that we can really kind of bring dignity to the practice of medicine, and really engender that in a systemic way. So I'm just going to skip ahead since I showed you this slide already. But also just to mention that racism often intersects with other social determinants of health. And we also can use these determinants can also be used to invoke implicit bias. Okay. These are just some reflection questions that I like to put. I think that we are all, as individuals who will render care, are rendering care to patients, we are all subject to bias. It doesn't matter what our backgrounds are, our personal experience really informs our bias. And on average, the human brain makes about 11,000 decisions every single day. Only about 40 or 50 of those decisions we make every minute. So, as you can imagine, your brain is making a lot of decisions just automatically. And a lot of that is influenced by our past decisions, our past experiences, and how we grew up, the environment in which we grew up. So, I always just like to pose these questions to you just to help to challenge your bias. One of the ways that we can start to implement reproductive justice in clinical practice is really just by having a manner in which we can listen critically, right? So when we're listening, well, I should mention before I go into how it is we listen, that 50 studies show that 2% of our patients feel that their symptoms are ignored, dismissed, not believed when they're seeking medical treatment, which is why listening is key. So when we listen, what are we listening for? We're listening for facts. We're listening for feelings, and also we're looking for feelings through body language. We're listening for intention, which is what are we really trying to achieve in this conversation, and what are we working towards? And of course, we're listening for filters, right? Listening for prejudices, biases, disempowering beliefs that patients may put forward, right? And the reason why listening is so key is because we know that on average, physicians interrupt patients in the first 7 seconds of the health visit. 7 seconds. That's literally giving them no time at all. So if we can just practice active listening, which means that we just literally give 120 seconds. If you can give more than 2 minutes, that would be great. But if we could just give 2 minutes just to let people speak about what it is that really brings them to the doctor's office, what is that ails them, and really listening for these 4 things, right? And as we're listening, how we can really validate and how we can really practice reflective listening, which is a little bit different. Reflective listening is really about allowing patients to letting patients see that we hear them, we see them, that we correctly interpreted what they expressed to us, and really giving them an opportunity to clarify what they mean. Right? This signals your acknowledgement of them, your awareness of what they said, and also connotes a listening presence. Right? So when we do that, we want to validate patients, right? Validate and normalize their feelings that we see and hear. We want to seek to understand. We want to ask clarifying questions. We want to kind of really understand how their experience has impacted their life, their health, right? We want to set the stage for reframing. So really allowing them to reflect on how what decisions might be good for them if we're really trying to encourage them to make decisions or provide a framework for shared decision making, right? And then we just reframe and reassure. We are really here to help frame and reassure. That's what we should do. It's not about telling people what they need for themselves. It's not about telling people what they should do. It's about providing information, education, and framing and reassuring. This is what we can do to ensure that we restore dignity and trust to the practice of medicine. So other tips, we can ask for permission, right? Whenever we're going to start speaking to people about very sensitive topics, particularly around reproductive and sexual health, it's important for us to ask for permission first. Some people may not want to talk about that. They may not feel comfortable with you. They may not want to go there with you. So it's always good to just ask them, hey, is it okay if I ask you about X, Y, and Z? I'd love to learn a little bit more about your experience with X, Y, and Z. As I mentioned previously, we want to avoid punitive and judgmental behaviors and attitudes, really checking our bias. We want to take a harm reduction approach. So in some cases where you may have a patient in front of you where it just seems as though it's going to be really hard to get to a concrete answer, or really take an approach that solves the problem, we can always take a harm reduction approach. Like, what is it that we can do to keep the patient safe in this moment? It may not be a long-term solution, but it will be something that, of course, respects dignity, something that respects autonomy, and also is something that keeps the patient safe in that moment, right? We can normalize shared decision making. And there's lots of research and data out there about how we can do that. For example, through the shares model and motivational interviewing, as I mentioned before. It's really important that we learn this skill of communicating with patients in a way where we're sharing information and allowing them to make the best decisions for their health and their families. And grow and support cultural congruence with providers and staff. So that really means that when patients are seeking providers that are culturally congruent to them, or they would prefer healthcare providers that, for example, are the same religion, are the same gender, are the same race and ethnicities, that those are connections that we as healthcare practitioners and our systems should look to foster and respect. Because data really shows that with this cultural congruence, there's increased trust. And with that, patients can make better decisions about their health. And of course, this leads to better outcomes. So I'll just review the takeaways for this talk today, and then we can open it up for questions. So it's really important that we understand what reproductive justice means. And this is the right to parent, the right not to parent, to raise children in fruitful and safe environments, and also to disassociate sex from reproduction, and i.e., really for us as healthcare practitioners to start addressing the issues of sexual pleasure as part of reproductive health. To really hone in on the point that current day disparities draw on legacies of injustice and discrimination, and that really much of what we see today draws on a historical precedent. Reproductive justice asserts that everyone can and will make the best decisions for their bodies, for their families, if empowered to do so. And we can empower them with information, with resources, but also with dignity and with respect. Patients want their experiences, their thoughts, their beliefs to be validated by healthcare practitioners and staff in order to feel heard and to feel respected. And these are the things that are really going to start to close some of the gaps that we see in the health disparities that we observe today. Okay, so here are some other frameworks that are associated with reproductive justice that we can also start to use. As I mentioned, reproductive justice is a health equity framework that really centers health, rights, choice, and access for the most marginalized populations, right? But it's also important for us to think about how reproductive health is really tied into that, which is like physical, mental, social health and well-being of all individuals who birth and individuals with uteruses, including those who are gender non-binary as well. It's important that we really speak about reproductive rights. So how it is that when we speak about reproductive rights, it's traditionally been associated with abortion rights, with contraceptive rights, but it goes far beyond that. It's also the legal protection to obtain and access all reproductive health services, including prenatal care, equitable birth, breastfeeding resources, childcare, and high quality health care. So rights really expand beyond those two things. And anti-racism, which is the ability to obtain healthcare free of racism and bias. It includes structural protections that make access more equitable. It includes care that's culturally responsive, honoring specific and appropriate requests from patients that are culturally appropriate. It also encompasses the inclusion of culturally and linguistically diverse health promotion strategies and practitioners. And it also implies challenging unhealthy environments that are reinforced by structurally racist policies and prohibit the ability to live and raise our families and children in environments where they can thrive. These practices also encompasses bodily autonomy, which I talked a little bit about before. And this really acknowledges that every individual is an expert in their own body and has the right to make decisions about that body. It encompasses, so reproductive justice is inclusive. It includes many things. It is many things. It encompasses many things. But I think most of all, it really challenges how it is that we think about reproduction in general, really taking into context all of these things, but also with that historical precedent. Okay, so I can open it up for questions now. Happy to answer any questions from the audience.
All right. Well, thank you so much for sharing that information. And thank you for providing the history of reproductive justice in the United States. We are now, as Dr. Liggett mentioned, going to move into the question and answer portion of the event and take questions from the audience. So I do see where we have a question. She says, "Hi, I'm interested in being a doctor scientist that researches how integrating cultural practices yields to improved fetal, maternal, and lactation outcomes. Do you know pro dev ops for me to prepare?" I don't know if she means like,
Probably
yeah.
professional development opportunities
Okay.
for me to prepare. Yes, there are actually a lot of opportunities to kind of learn and grow. I think much of the work is really happening on the ground with a lot of nonprofit organizations and NGOs that are kind of already doing this work around lactation equity. There's one organization that comes to mind that's called Nurturely, and I can put it in the chat, which is specifically doing work around maternal health, lactation outcomes, and they really focus heavily on breastfeeding and human milk feeding. And so that would be a great organization to connect with. There are also, I think, more and more CME opportunities or continuing medical education opportunities as well, where people can kind of just learn more about the history and praxis of reproductive justice, about this legacy of reproductive injustice as a way to really start to kind of understand the history, right? Because the history really informs the present. And I think once you kind of start to kind of understand that history in a lot of detail and also kind of what motivated some of the policies, also motivated the creation of certain structures and cultural practices, then you can start to ask new questions for yourself, questions that you might want to answer, questions that you might want to research, questions that may also inform what it is, what direction you would like to take as well. I hope that answered your question. I can also type the resource in the chat.
And thank you, Dr. Liggett, for answering that question. I'll let you go ahead and type that information in the chat. All right. So I know you mentioned some information about doula. So can you first define what a doula is for those of us who may not know, and how doulas make an impact in a patient's birthing experience?
Yeah, so doulas are basically, in a traditional sense, have taken on the role of community health workers who have really aided in support of birthing people. And that in a traditional sense, right? So that includes really providing education and support during the pregnancy, really garnering resources for the pregnant person, whatever resources they may need to be healthier, kind of helping to reinforce or digest some of the messages that doctors may tell patients that they didn't quite understand. Really providing some of that education around how you provide care for infants, how you breastfeed, how you care for yourself, how you exercise during pregnancy, how it is that what are some tips for pain control during birth? And in many cases, labor doulas will actually attend the birth with the birthing person. So they'll be there with them to really act as an advocate for them, really hoping to ensure that they can, that their birth choices are respected, and really advocate for them in the event that that birthing person can't advocate for themselves. For those of you out there who've had children, you know that oftentimes it's very difficult to be making all of these decisions, have all this information thrown at you. And it's quite nice to have somebody who's well versed in the healthcare system, who can communicate with healthcare practitioners and healthcare staff your needs, your desires, and provide that additional support. They're also often there during the postpartum period too, to really help with that transition with breastfeeding and also just self care. So they have a big role. And there's a lot of research now that's coming out about doulas that really show that they do impact outcomes. They lower C-section rates. They lower the need for reduced risk of or the reduced need for Pitocin or labor augmentation strategies. So pain control is often better controlled when there's a doula there. People feel more supported. There's better breastfeeding outcomes. So there are a lot of really great benefits to having a doula. The downside is that in many cases, insurance does not cover it. So it's really something that only individuals of means can access. But in some states, that's changing, particularly in New York. Can't really say what's happening in other states. But currently, the state is looking to see if Medicaid in particular can cover doula services to kind of expand access.
Okay, well, thank you for providing that information. And for those of us who are future mothers, going to have children, it's good to know that the importance of having a doula. And then I do see we have another question. And this is from Miss Beverly. How can one engage in how can one engage in health and policy efforts to improve how more move forward in redesigning systems that aren't working for many people?
Yeah, so I would say the best place to start is really in your own institutions, because Although when we think about kind of systemic injustice, we tend to think like very broadly about what that means. Like, oh, like you're thinking about the federal governments and the judicial system and kind of all of these stipulations that they're passing to restrict access to abortion and things like that. But sometimes the advocacy can really start in your own institutions where people already know you and respect your voice, and where you already have a seat at the table, right? And really kind of looking at what are some of the policies and practices in my institution that could be more equitable. When we all kind of come to a round table to make decisions, it doesn't matter how big or small these decisions can be. Whose voices are represented, whose voices are not represented, which people in particular are we speaking about here, and which individuals are we leaving out, right? So even just like posing that way in which we even start to think about how it is that we allocate resources and how we are more inclusive even in the systems in which we work, right? Yeah, so I think that's always a good place to start.
Thank you for answering that question. So I also have a question. I appreciate you sharing the pregnancy options counseling for reflective listening. So has there been any data sharing regarding the outcomes, especially with patients of color who appreciated that approach?
Yeah, absolutely. These are all validated tools that have been validated in the research and really do show that patients um, really have better satisfaction with their care when these skills are adopted. And really, why that's important is because when patients have higher satisfaction and feel like they can connect with the physicians or the healthcare practitioners that they're working with, that means that they're more likely to make informed decisions about their health and more likely to take ownership and empowerment over their health. And when they feel empowered, that means they're more likely to initiate behavior changes that we really hope that they would initiate. So that in turn would improves outcomes, right? So it's really, I think, much of what we see with health disparities. I mean, there's a lot of systemic barriers, but I think just in terms of communication and kind of changing the power dynamics between ourselves and patients is going to be key to also helping to empower patients to take part and ownership in their health as well, which has traditionally, as I mentioned from the many examples of reproductive coercion and reproductive injustice in this country, has typically robbed them of that autonomy to make decisions about their own bodies. So, really using these communication methods is a way to restore that.
Thank you. I do agree. I think having that communication and just being able to have that empathy and understanding, especially for patients of color, who have been affected by the reproductive injustice in this country.
Mhm.
So I do have a question. How can future physicians impact reproductive justice as a college student or non-traditional pre-medical student?
Yeah, I think as a student, sometimes, as a student yourself, you're trying because like healthcare is so hierarchy based, and everybody kind of knows their role, in the system. I think sometimes it's harder for students to really advocate when they see things that may appear or seem unjust to them. However, there are still ways that even students can advocate, right? And I think a lot of that is just based on modeling behavior, which is critically important. Or advocating for the patients, like taking ownership of your patients and really advocating for them, being that voice in the room, whether it's on rounds or when people are speaking about the patient in terms of making assumptions about them, really challenging those assumptions, asking those probing questions when people kind of make statements that are implicitly or explicitly biased, really challenging those statements and saying, hey, I don't really quite understand what you meant by that. Are you able to explain a little bit more about what you meant by that? Right? Because There are differences in the intent. Like most people don't intend to be biased towards patients, but it's really not about the intent. It's about the impact, right? It's about the impact that it has on patient care and also the patient experience. So one way that we can interrupt that is really just by asking the questions to our colleagues, right? And really asking the questions to our systems, right? Instead of just being hyper focused on blaming individuals, we really kind of need to take a step back and look at how it is that our systems reinforce these behaviors, these practices as well, right? And healthcare is wrought with many of them, many of these ridiculous rules and policies that advantage some and disadvantage others. The race correlation calculators is one example of that, right? Like how it's become, we're kind of now incorporating even these racist and biased ideas into what's considered evidence-based medicine. But we know that race is not real. Race is a social construct. It is not a biological construct. So to assume that there needs to be a race correlation because there are biological differences between individuals is flawed, right? And we can see how that impacts outcomes. So I think just starting to really challenge these things we see at the systemic levels and how it is that we can start to change policies and practices that impact the population as opposed to just calling out individuals. I feel like for close colleagues, it's always important to provide feedback to them from a place of respect when people are saying and doing things that really rob patients of dignity. And I always encourage people to do that if they can, if they feel safe to do so, because I know that's not always the case.
Thank you so much for that. We do have one more question, if you're okay with answering this last question.
Sure.
So the last question is, what does a physician advocate look like? And what are some actionable items physicians can do to advocate for their patients?
Yeah, so I think physician advocates can look like many things. It really depends on what you feel like your superpower is. Um, for me, my superpower is speaking. So really communicating in a way um, where people can kind of really understand, where I can really break down terms and concepts, thoughts, feelings, beliefs, and history to individuals such that they can really kind of get a deeper meaning of where these behaviors and practices come from. Some people advocate in the form of writing about their experiences personally, writing about patient stories, lending a voice to patients by really writing their story, sharing their story with individuals such that it can be a learning experience for all, because storytelling is extremely powerful, right? As a way to kind of really change people's perspectives on issues that are very, very highly charged. Other ways can be organization or community organizing is another way. If people are really into community or grassroots organizing, that's something you can do. Volunteerism is another form of physician advocacy. Um, Finding a way to improve initiatives in your clinic, taking initiative to start some sort of volunteer campaign where people donate goods or services to community members who need it. Or even just in your own clinical practice, looking and seeing, how can I just make my clinic better for the patients that we serve? Whether that's, having patient information in English and in Spanish, where you yourself can really take initiative to ensure that that information is available because you noticed that there was a gap there, or providing some other necessary service that you feel is key for patients to really get high quality care. So that's another way. And that's kind of like something that really just happens in your own kind of workspace that you can advocate for change. Really, physician advocacy really can look like many things, which is really just, what are the ways in which I can impact change in my sphere? It can be a small sphere of friends, of neighbors, of colleagues, or it could be a larger smear, like in your clinic largely, it could be in your community, or if you're looking into getting into politics, that's a whole nother level of advocacy. But I think it's critically important that we as physicians get involved if we can, because our voices are not being heard. And we are really the people, the logical ones in the room, all healthcare providers, the people who are patient adjacent, the people who can tell these stories and really kind of lend truth and credibility to what is really happening on the ground, right?
Well, thank you, Dr. Leggett. Again, thank you for answering all of the questions that were asked from the audience in the chat and also some of the questions I had. Again, thank you for your amazing presentation. We appreciate your support of the Student National Medical Association and our pre-medical students and MAPS associate members. We would like everybody to please stay tuned for part 2 and part 3 of this webinar series. And thank you, Dr. Liggett, for kicking off this webinar series. Also, please do not forget to register or support if you can come and attend the annual medical education conference, also known as AMEC. This year, AMEC 2024 will be hosted in New Orleans, and it's from March 27th through March 31st. And for updates, please make sure to follow us on Instagram at national_SNMA_MAPS. And thank you again for joining us this evening. And thank you, Dr. Leggett. Again, we appreciate you being a part of this webinar series.
Thank you so much, guys.
All right, thank you. You have a good night.